welcome to my channel Pediatrics and Life Tips. In this video, I will talk about pediatric psoriasis. Psoriasis is an inflammatory autoimmune related disease characterized by inflammation and keratinocyte proliferation. It is a lifelong disease with remission and exacerbation. Etiology and pathogenesis of psoriasis. Within the dermis, dendritic cells are activated by self-antigens, and these cells release cytokines such as interferon gamma, tumor necrosis factor, interleukin 12, 17, 22 and 23. These cytokines recruit T cells. Now activated T cells release cytokines that induce proliferation and abnormal differentiation of epidermal keratinocytes. Now its genetics. Psoriasis has a complex multifactorial genetic basis. Major psoriasis susceptibility gene is a human leukocyte antigen CW*0602, which encode a class 1 major histocompatibility complex protein which is involved in recognition of self-antigens. There are certain factors which contribute to disease onset and flares. These include bacterial and viral infections, trauma, physical or emotional stress, tobacco use or secondhand exposure, certain medications, and childhood obesity. Now I will discuss the clinical features. The onset occurs in first 2 decades of life in only 30% of the cases. There are different types of psoriasis which include plaque psoriasis, guttate, pustular, napkin psoriasis or psoriasis vulgaris, erythrodermic psoriasis, linear psoriasis, and inverse psoriasis. In children, plaque psoriasis is most common, which occur in more than 80% of cases. These occur in form of erythematous papule, which coalesce to form plaques with sharply demarcated irregular borders and thick silvery or yellow-white scales. Now, removal of this scale results in pinpoint bleeding. This is known as Auspitz sign. Preferred sites are the scalp, knees, elbow, umbilicus, superior intergluteal fold, genitals and ear canal. In plaque psoriasis, Kopner phenomena is present, that is, new lesions appear at the site of trauma. Plaques are generally asymptomatic, however pruritus is more common in children than adults. Nail involvement in psoriasis include pitting of the nail plate, onycholysis, that is detachment of the nail plate, subungual yellow-brown discoloration and accumulation of subungual debris. Guttate psoriasis occurs predominantly in children. There is acute eruption of numerous oval or round papules which are less than 1.5 cm. Preferred sites are trunk, face and proximal portion of the limbs. Onset of guttate psoriasis usually follows streptococcal pharyngitis, but it may occur after perianal streptococcal infection, viral infection, sunburn, and withdrawal of systemic corticosteroid therapy or tumor necrosis factor alpha inhibitors. Clinical course ranges from spontaneous resolution to chronic disease. Next is the pustular psoriasis. In this, there are recurrent episodes of sudden onset of fever, malaise, extracutaneous organ involvement, and a diffuse erythematous pustular exanthem. Napkin psoriasis, which is also known as psoriasis diaper rash, occur predominantly in children less than 2 years old. Psoriasis vulgaris is the most common type of psoriasis in adults. This involves the scalp, extensor surfaces, genitals, umbilicus, and lumbosacral and retroauricular regions. Other rare types of psoriasis include psoriatic erythroderma, linear psoriasis, palmoplantar psoriasis, and inverse psoriasis, which is present in intertriginous areas and flexure areas. Now the complications and comorbidities. First is the psoriatic arthritis. This usually occurs in hand and feet joints, but in rare cases large joints may be involved. There is stiffness, pain, and progressive joint damage. Ocular psoriasis is also important. This produces ectropion, trichiasis, conjunctivitis, conjunctival hyperemia, corneal dryness with punctate keratitis. Now, secondary skin infections are common in psoriasis. In pediatric psoriasis, there is increased risk of obesity and the associated metabolic syndrome, which consists of hyperglycemia, dyslipidemia, and hypertension. There may be stroke, myocardial infarction, and possible increased risk of lymphoma and inflammatory bowel disease. Now the diagnosis. Psoriasis is a clinical diagnosis. However, biopsy and histopathology of the lesion shows parakeratosis, acanthosis, elongated reedy ridges, neutrophilic infiltrate in the epidermis with microabscesses formation, dilated dermal blood vessels, and lymphocyte infiltrate in the dermis. Now I will discuss the treatment of psoriasis. Treatment varies with the age of the child, type of psoriasis, sites of involvement, and extent of the disease. Physical and chemical trauma to the skin should be avoided. Now I will discuss the treatment of psoriasis. Generally, the treatment is divided into 4 steps of 4 groups. First is the topical therapy. For body, the topical drugs include emollients such as vitamin D analogs, which include calcipotriene or calcitriol. Other agents which can be used include mid to high potency corticosteroids, retinoids, tar preparation, anthralin, and keratolytic such as salicylic acid or urea. Topical therapy for facial or intertriginous lesions include low potency topical corticosteroid, topical vitamin D analogs, or calcineurin inhibitors. Topical therapy for scalp lesion. First, phenol and saline solution is applied to the scalp to loosen the scales. This is followed by washing with tar shampoo. High to superpotency topical corticosteroid is also used. Topical therapy for nail lesion include only high potency topical corticosteroids. Now the second step or the group of treatment is the phototherapy. This include narrow band ultraviolet B irradiation, Gokerman treatment which include narrow band ultraviolet B irradiation plus tar. This is used for older children with extensive disease. Excimer laser ultraviolet B irradiation is used for resistant plaques. Natural sunlight is beneficial for mild cases. Third step is the systemic therapy, which is used for severe and generalized psoriasis. This treatment includes methotrexate, oral retinoids, cyclosporine, or oral retinoids plus phototherapy. Now the fourth step includes biologic response modifiers. These drugs are mostly used in the adults. These include tumor necrosis factor alpha inhibitors such as etanercept or infliximab, T-cell function inhibitors ustekinumab, which is a human monoclonal antibody, anti-interleukin 17 and anti-interleukin 17 receptor agents, adenosine receptor agonist, Janus kinase inhibitors, and phosphodiesterase 4 inhibitors. Now in psoriasis, long-term monitoring is important for comorbid conditions like obesity, hyperglycemia, dyslipidemia, hypertension, arthritis, uveitis, etc. And also long-term monitoring is important for treatment-specific side effects as of corticosteroids, skin cancer in the case of phototherapy, liver disease in methotrexate patient, and tuberculosis exposure in patient on biologic medication. Thanks for watching this video. Please like, share and subscribe to my channel.